morning, everybody. It's such a privilege to be here with you guys and everybody else in this journey of hope. And I would like to thank Mike and Liana for the great summary that lays the groundwork for our next session. Before I go further, I would like my co-panelists to introduce themselves so that we get to know everybody. Just to apologize for Dr. Mammon. He's not able to make it with the flight delays and cancellations. So we'll move on to Dr. Copeland.
Hi, I'm Ashley Stealing Copeland. I'm a pediatric neuromuscular neurologist here in Texas. I'm in Austin at UT Del Med at Dell Children's.
Hi, I'm Nick Desmondui. I'm a pediatric neurologist and neuromuscular specialist. I'm in Nicholas Children's Hospital in Miami.
Good morning, everybody. I'm Diana Castro. I'm a pediatric neurologist, also adult neurologist these days, a neuromuscular specialist. I have my own center in Dallas, in Denton, Texas, a nonprofit neuromuscular clinic and a research clinic as well.
Thank you. I'm so glad that we all can come together, and this is a really pivotal session, especially after what you've heard of the changing landscape for therapeutics. I can attest to that explosive increase in the medical advances. Just as I recall, when I first attended a meeting, an MDA meeting more than 20 over years ago, and I just woke up to this really dark early morning with this little sun peeking out, and as the sun went up the sky and just the Tucson hills and all, it was just blue and bright. And it reminds me of the journey that I have walked since then with our Duchenne community, when it was that little spot of that sun, but it's now getting brighter and brighter and brighter over the years, as you have heard what Mike has summarized of all the explosion of research advances and the therapies that we have. So to recap, in the year 2006 was our first clinical trial for Duchenne's with atolurine. And since then, we had 2016, the first FDA-approved drug for exon skipping with Exondys, followed by the other exon skipping drugs that we have. And currently, we have had like 2 new drugs that were approved just the past year or so with Agamree, which is Vamorolone, Givinostat, which is Duzovant. And you can see that that has led us to the point now where we have different options. So where the rubber hits the road is where we interface with our families with this very hard decision of making choices. And so I think this session right now, we would like to have us, colleagues in clinics, share with us how decisions are made with families on the care options to explore now with all the treatments that's available that we have. And then the second portion, we can talk a little bit about trials. So I would like to have Dr. Castro share with us like this whole issue of the care decisions and options in this era of plenty of choices.
Of course. Good morning, everybody. Thank you, Brenda. And I mean, people that knows me, I've been doing this for a little while already in my center. It's the 3rd year. And what we have achieved is time, really. What I'm able to do is spend more time with the patients and not having to rush through clinic and trying to move as fast as usually hospitals would like us, because I don't think this disease is not for us to move fast in clinic, because you have to really learn about the families, you have to learn about the patients, their cultural background, language. There are so many factors that I learn out of each of the families I take care that helps me guiding them a little bit. It's not perfect, but I know where we're going, right? Where are we going? For example, I give you an example. There was a family who were talking about gene transfer therapy, but the mom is not as consistent, so, and then she doesn't like prednisone, so it's, I knew it was not gonna be the right decision for that specific patient. This is a single mom, difficult with transportation, a lot of she's always been against the medical, like the medications mainly. She always comes to see me, but the medications are like, so I knew it was gonna be a struggle. So we had 3 different conversations. I had 2 on the person, and then I had 1 on video. And we talk until 2 weeks ago, both of us was, you know what, let's just don't right now, because it is not a good option for him. He's very autistic. He suffers with every blood drawn. So it was gonna be a nightmare. We have him on a very small amount of steroids because the autism causes behavioral issues. So my point is that this is not perfect. There is not a recipe for anything that we're doing. And you may go to different physicians and may get different opinions, and that's okay. There is a standard, obviously. There is a standard how we treat patients, but in terms of the new medications that are coming, we may have different opinions. It doesn't mean it's wrong. It's okay. It's okay to have discussions, and sometimes we have discussions with our colleagues to figure out what we can do better. So to me, it's just try to get the time. You guys as families ask for the time for you to have all your questions answered. Don't make any decision without having 100% understanding of what's going on.
And you made a very good point. It's all individualized care. It's patient-centric and family-centric. So I know families do a lot of comparing on social media, who gets what. But I think you made a very good point that each family is different. And in such a circumstance, with the other considerations for the impact of the social situation and the needs that will affect the ability to cope with the intense treatment, and that is the burden that is very, very different. And we all face that in our clinics. And so for families, I think it's important to note that, not to compare with the Joneses, but to really discuss with your provider every aspect. So your clinic visit is going to be much longer than 15 minutes or 30 minutes, but to really involve the non-medical aspects of considerations for therapy in the choices of new drugs. I find that even in the context of the standard of care of steroids, which by the way was studied in the 1980s, but the recommendation that steroids is the standard of care only came about in the early 2000s, like 2004, 2005. I still come across newly diagnosed families that have concerns for steroid side effects, and the fear of embarking on this long-term therapy. And I think we still need to get back to the basics of standard of care before adding on it to the new layer of new therapeutics. So not to jump to the new therapeutics and omit your basics. I think that's one reminder for our families is get the basics right. Steroids work, and we have changed the outcomes, but there's a lot of homework to mitigate the side effects of steroids, to get the most out of this benefit-risk ratio. So I think, my clinic's a little different from other clinics, so maybe Dr. Stanley Ashley Mivis can help us out with how their families kind of deal with this changing landscape that is really converging at our doorstep, the clinic.
I think y'all are correct in saying you have to really take into account who the patient is, who the family is, and what their background is. I like to do that as well with all my, not just my Duchenne patients, but my other patients that I see as well. And I like to, sort of lay it out. Okay, these are what our options are. Starting, with the foundation, starting with the steroids. Like, this is, you know, what we have the most data on. This is what we know works, and, you know, these are what we know the, you know, potential risk are. These are the benefits, and so, you know, make a choice from there. And then, of course, you know, unfortunately here in the U.S., a lot of times insurance sometimes, you know, lovely dictates sometimes what we have to start first. You know, oh, you have to start prednisone or prednisolone first, even if we think for that child it may not be the best. But, you know, the good thing is oftentimes, you know, I'll try to see those patients back that I think, yeah, this is going to be an issue. You know, see them back in 4 to 6 weeks, and then you can document, okay, my child is, you know, has had, you know, this adverse behavioral effect, has gained, you know, X number of pounds. And I find that, you know, that's helpful when you're needing to change from one steroid to another.
Yeah, I ditto everything that's been said so far. I really think time is an important point because it takes a lot of time to discuss and educate the families, one, you know, newly diagnosed patient, what the disease is, how it affects many organ systems, not just the muscles, who are the team members that they're going to have to build as their core people that follow the patient throughout the years. And I think this is where I could see how things have evolved to over time. So initially when I first started the clinic, it wasn't a clinic, it was just me trying to do it all by myself. And I've been able to luckily recruit team members and really make a multidisciplinary team where now I could take a little bit more time just as the neuromuscular specialist discussing the medications, because there's so much to discuss, there's so much to keep up with, you know, not only for families, but ourselves as providers too. So it's nice that I have an endocrinologist in clinic and a geneticist and other people that then can take those aspects of it, and then I don't have to do that, and that leaves me more time to be able to discuss all the new medications and clinical trials and really educate the families and try to make the best decision together as to what the right choice is for that family, for that patient, for their social situation, right? Because we have to talk about medications, school, what's happening, mobility, braces. I mean, it's a long, long list of things. And again, like Dr. Castro mentioned, there's only so much time we have for that visit, and so much perhaps that the family can take in all at once too. So that's where building that rapport and that relationship takes time. You get to know the families throughout the years. You get to know what's important for them. You know, what are going to be the top things that you really have to discuss in the time that's allowed, and then having the team members, it takes a village to follow through with all those individual needs that perhaps you didn't get to address because it's a lot for every visit. So I think that's where everybody's going to do it a little bit differently depending on the resources that you have at every local institution. But I think the theme is the same, that we all have to take everything into account, and it's not going to be like a quick and easy protocol where you check boxes and you have to be on this at this age and on this at this age. It's going to be different for everybody.
Yeah, I think we started off clinical care, I would say, pretty straightforward, right? Steroids, no steroids, and I think the discussion a lot was just side effects of steroids. But now I think we are into the new drugs, and I think one of those, as you said, requires very frequent monitoring for adverse side effects, and I think it behoves like the clinic working closely with the family to monitor the side effects, the blood work that is once in 2 weeks for 3 months, and so on and so forth. So how, I think, should we kind of help families who are really what I would call the group that is more hand-holding versus the group that is very well informed and they can be relied upon to get the regular blood work done. So it's a challenge, but I think it'll be nice to hear how you're able to help that group, because I think we have that families that lag behind from the benefits of these new treatments if we don't provide them with that support.
Yeah, no, it's complicated. It's not easy. I do have my families that know everything. They know first for me about trials and things that are coming, and you're like, wait, let me Google. So there are some of those families that are amazing and keeping up with everything. I don't know how they do, because I cannot keep up with my life and my 2 children. But there are some of them that are just amazing. The ones that have more struggle, what I see a lot of times in Texas, we have a lot of Hispanic families, and a lot of people end up, the mom is the primary caretaker for a lot of youth, for most of the families here. Mom is the one that stays closer, to the care. Not that the dads are not doing anything. It's just that it is what it is, right? It is the way in medicine in general. So with those moms, I give my cell phone to my patients, which I know it's crazy, and my husband is still thinking I'm crazy. But if I'm gonna give gene therapy, I cannot not give my cell phone, because I'm gonna go crazy if I don't know what is happening at every time. And what I try to avoid is having to go through the clinic to get my answer, because I may be busy in clinic the whole day and it's an emergency, right? So I have to answer. So that's something that has helped me a lot in my practice, and I do this with pretty much every patient. We give them calendars, paper calendar. We give them a calendar, an email. My MAs are on top of everything in terms of the blood work, making sure that it's ordered, making sure that the patients are actually going. Because sometimes you put the orders and then they don't get them. So you have to go back and understand, tell them, why is that we're needing this blood work, right? Like, for example, we do Visat, with Givinostar. You have to be on top of triglycerides and platelets, period. That's not an option. So I think it depends each family, but what I try to do is always try to be closer to them, which, I don't want to open this can of worms yet, but the problem with our care right now is that we have a system that is built for people with short-term conditions, right? You go there, you're treated in 15 minutes, you're out, you maybe get a follow-up on 2, but it's not built for chronic conditions, and definitely not for rare disease. And I think that's where we have to start as physicians and families, putting our foot and say, we need to have a break ourselves too. Many of my colleagues are leaving the academia, leaving the universities, and going to pharma because they're exhausted. It's a lot of work, right? And I don't think people understand that, and definitely administration and hospitals don't understand that. So we end up doing a lot of things by ourselves, with our nails, like every day, little by little, which I'm gonna keep going, but it worries me that there's gonna be a point where we're not gonna have a lot of physicians treating these conditions, because, people are getting tired, and the system does not help us. So yeah, it depends, each family.
And I find like building the team that we have helps. Like my team, we've got very good team players. I have a nurse practitioner that is just amazing with getting all the monitoring of all the labs needed. So we do have a follow-up of that. That's one way to keep track. And I think, but first and foremost, I think is have a good discussion with the family before the decision to start such a medication with intense monitoring, to have them. It's almost like an informed consent process for a therapeutic drug that is in a trial, because you have to tell them all the side effects, all the risks, and that comes with it the burden of the monitoring. And I do have some families who, after weighing the benefits versus that risk and burden, that they may opt out for it for the time being, because it's an approved drug, and it's not like there's a deadline for enrollment for a clinical trial that they have to make that final decision. They would have more time to weigh in a little bit, and also to assess the outcomes that we're seeing in the real world with our real world data. And I find that helps ease a little bit in how we manage expectations, because each time a new drug is approved, you can see all the emails and all the phone calls coming in, and that needs to have, we have to have that process of informing them, and that's the time invested, I think, for them to adhere to following up the monitoring needs for safety reasons and for follow-up. So that's kind of having a team to assist. I don't think the provider, we cannot run a one-person show. Yeah, so that's my experience from a team that has been very cohesive.
I think number one, I just want to give a shout out to all of our social workers, because I could not do my job without having them to assist me. I think, you know, social workers are amazing people, and they've done so much, especially like in the era of gene therapy, with helping, you know, making sure if families do need assistance with transportation, or, you know, like, oh, we're having to miss work. I've had that situation recently where, you know, we had some adverse effects, and so, you know, parents having to miss work, and you know, and you're trying to pay the bills, things like that. So, I mean, I rely on them heavily in my day-to-day practice. They do a wonderful job. In fact, Kayla Richards, one of our social workers, is here. So if you're, you know, for your siblings, she'll be leading one of those or two of those discussions. So they're great. And then our nursing staff too, being able to, you know, check in with the families. Hey, you know, make sure and do this, like with the Javinostat. We've had some people try to get behind, you know, on the lab. So just a little friendly reminder, hey, we need to get this done. I also, all of my gene therapy patients, Duchenne, estimate they all have my number too, because sometimes, you know, especially if they're in rural communities, they show up at you show up at a small emergency department. I'm sure, you know, you all families know that, you know, some of those providers in the smaller hospitals have never heard, maybe they've heard of Duchenne, but they've never taken care of a patient with Duchenne. And you tell them that you got a gene therapy. And, you know, even some people in my, you know, specialty children's hospital don't have as much familiarity with it, because it's, there are a few of us who do neuromuscular medicine. So it's really helpful to be able to answer some of those urgent questions and stay on top of things.
I think, again, this is where it's important to educate the team as well, especially when we know that new medications are coming out. So if we were lucky to participate in clinical trials for that medication, the team already have some familiarity with it. But if it's another new medication that they're not familiar with, I think all of us, you know, it's important as we prepare ahead of time to get educated regarding the medication, the side effects, how it's given, what sort of monitoring you need, so that way our nurses or our staff could, you know how frequent they have to track the patient. And then the other part of it is like on the authorization side of it, right? For our nurses to also know what's a process to get this drug approved by an insurance company, what are all the boxes we need to check, so that when we submit it the first time around, we send all the information that's required, and then, you know, get a denial, and then that takes longer to get that turned over. So getting it right from the first time is always so important. But that takes time. That takes time for us as a team to understand, you know, not only the medical part of it, but the insurance part of it too. So I think that's where it's important to build that team that you trust, and then invest in educating them according to each role, what they need to be doing in order to be able to help our patients and do it correctly and be able to rely on them. So if I know I educated them, you know, for gene therapy, this is what we need to be doing. We have a whole protocol. We give those appointments, you know, on the day of infusion, they're getting the list of all their appointments and when to do the labs. And it's a learning curve for us as providers too, because how many times the first few patients were getting labs locally, right? And we learn quickly, oh, that's not good because they get lost. The samples get lost and we don't get results, and we're seeing them for follow-up and we don't have lab results. And then having to regroup and readjust and learn from that experience so that that doesn't happen again with the next family. So I think those are all important things that unfortunately perhaps insurance don't understand, or hospital administrators don't understand why it takes such a big village for this particular disease and why it's so challenging, and there's so much that we need to be doing. So then we have to educate them as well as to why we need funding for social workers in our clinic and nutritionists and nurse navigators or nurse practitioners, or all of the above. So it's a learning process, and we're all doing it together because so much is changing, and it's changing so quickly. So I know you had a good analogy, so I'm not going to steal it from you. You can say it.
And following up on that note, you highlighted a good point on insurance, because a lot of families, have different insurance policies, and payer policies are different. And with each new specialty drug, that families may not be aware of this, but the due process to get prior authorization may take a while. And I think even for steroids, they won't even approve deflazacort unless you've tried pregnancy. So I think for families to kind of understand a little bit what their policy is, so in making decisions for those who are able to make choices for their insurance plans for the next year, will be helpful, because sometimes we have policies that just suddenly state that this is not covered. So that's one thing that we bear in mind when we have new drugs, and the time it takes to get it started depends on how long the prior authorization takes. And it again, it falls on the team to be able to provide that peer-to-peer or the documentation to justify why it should be approved. And some are pretty strict based on the criteria for clinical trials, that this was studied in ambulatory patients, and therefore some policies strictly don't approve it for non-ambulatory. And I think for families to understand, all that challenges, and for us to be able to kind of work through that in terms of how to justify a drug for the patient. And it's understanding the patient well. So that's a good point that you brought up about insurance. And I think we probably can talk a little bit too in the up and coming newborn screening, right? That is approved in several states now. And I think that then translates into a new population in clinic, right? We are so used to having early ambulatory, late ambulatory, early non-ambulatory, late non-ambulatory, and our care needs are different for each different phases. And now we've got, in the clinical situation, think about welcoming the pre-symptomatic. I see some baby Duchenne's just because they had been diagnosed by family history or incidental finding of elevated liver enzymes. And, I have a few, 12 months old, 9 months old. And I think as newborn screening becomes more prevalent, we will have to consider taking care of the pre-symptomatic and supporting the very early diagnosed families. That is a shock to them when a boy is still pre-symptomatic, and how we would prepare them for the treatments, because that probably will bring to our next session about the number of clinical trials and how we're going to navigate that. So I have not really seen, as I said, a lot of baby Duchenne's, but the nice thing is that, they do not develop like the motor difficulties till later, but of course it's the prime time to have a proactive approach at that time before age 3 to be able to ensure that, hey, just get that range of motion, the stretching, as a day-to-day routine when you're changing your nappies or your diapers, and also at a good starting time to think about diet, right? Because we're educating all our families towards like a healthy diet for being on steroids. We do not have a special diet for our boys on steroids or our patients on steroids because we just advocate the healthy diet. There is no excessive calories, no excessive carbs, low glycemic index for everybody, good protein diet, fruits and vegetables. So that kind of diet doesn't start with starting steroids. It really starts as a family. And so I think for the baby Duchenne's, I call it, that lays the groundwork, and it's very effective, I find, that nutritional input, because it really is lifestyle medicine, right? There actually is a branch of lifestyle medicine out there, but if we apply that in all our clinics, I find, you live well, right? That is more mental health and stuff like that, we take care of the other kids. But you eat well, you sleep well, you breathe well, and then you live well, right? So I think if we apply that from the beginning for a baby Duchenne's, it lays the groundwork. So I think that's what I've seen, like the little babies that have grown with us, that they get this whole routine of, the range of motion, the stretches, keep them away from contraction. Especially the baby Duchenne's, I find some of them have some hallmarks of like muscle hypertrophy. In some, you can actually palpate the very firm muscles and some tight adductors, so you can always start from there. So I don't know, whether you have seen many baby Duchenne's, but if you have, what's your approach? But basically, we are going to expect to see some of those new generation patients.
Yeah, I actually have had a lot of lately. I don't know why. I'm getting more and more younger patients, and that was something. I had a meeting yesterday with some of the pharmaceutical companies, and that was one point that I made is we need to have registries early, like one place where you get all the information about all of these new kids that are coming, because newborn screening is going to bring them. Until we get there, we're still getting those little ones. And many times it's like, what do we do, right? Yes, you have to do the basics and you have to start there. But I think it's so important to try to get people, to try to get the information in one place for all of us to learn by the time we have newborn screening. Everything you said, it's exactly what I do. I think starting early makes life easier down the road. Like you don't want to start having to start a 10-year-old on AFOs, on braces, nighttime braces. It's very different than starting one at 2 years, right? So we're always checking very carefully, my physical therapists, everybody checking carefully and try to be proactive from the beginning, 100%. I talk to them about constipation all the time. I talk to them about diet. We do have a nutritionist as well, but it's a job that needs to start as early as possible. I have a little bit of, my only issue with that is also for them, you get diagnosed, you have your baby looks absolutely normal. And then your options for treatment are pretty much at the beginning, none or not many, right? That's my only issue, because we went through this with a spinal muscular atrophy. We have newborn screening, but we treat these kids within the first 6 weeks of life, right? We're ready to go. But with Duchenne, I just don't know where, how fast are we going to move there to be able to start enrolling kids or getting trials in younger population, which I think needs to happen. But it also collecting data, all of us as a whole, not per company, because I think it's dumb that each company wants to have a different registry. We cannot support that in clinics anymore. We need to have one place where everybody gets the data in one place.
Yeah. I totally understand, yeah, the point of, yeah, for a lot of the patients, like you do have to wait to start treatment, with the exception of some of those who, of our patients who meet criteria for based on their mutation for exon skipping. But, you know, also to the point of we still have some boys in our clinics to this day who don't get diagnosed till they're 8 or 9 years old. And then we're trying to work from behind.
Catching up.
And especially, I know here in Texas, with our Hispanic population, sometimes they can be even delayed past the national average, which, you know, is still around 5 years of age and hasn't really changed since, I mean, I was in, I don't know, way before I was in college, I think. You know, it's been many years, like 30 years or so, and that number has just sort of stayed stagnant, and then it's delayed more in boys of color, in particular in the African American population. I had a family who showed up at the emergency department. The grandmother brought the child to the emergency department. And this child was older, and no one had, you know, no one had picked this up.
Yeah, that doesn't make sense. Yeah.
That's where
That's where newborn screening
will-
will be
will-
helpful.
will be
We'll
helpful.
change that landscape.
100%.
Yeah.
It's just that it's going to be
It's-
that weird time, that
It-
awkward time that is like,
Right.
okay, your son has Duchenne, but there is nothing besides your basic care. There is really
Right.
nothing we can give until this point, right?
Yeah.
But I agree with you.
It's-
I mean, Texas, we're one of the worst in terms of access to care, early diagnosis, 100%. And this is a big state, and there are not enough of us.
Yeah.
That's the problem too, right?
I think we have to do a better job too of re-educating, you know, some of the primary care providers as well, because, you know, I know it's very easy for us on stage to see, you know, oh, this kid had, you know, years ago was seen to have an elevated AST and ALT, and we know, oh, well, why did they go through this whole GI process? No one ever checked a GGT, which is the liver-specific enzyme. I've had kids, and I'm sure y'all have too, boys who have gotten liver biopsies before they ever came to see us. And so also that would be helpful for newborn screening.
Yeah,
as well.
100%.
I think that's the only way we're really going to make a dent in changing the time to diagnosis, right? Because there's been so many efforts to educate people.
Yeah.
But again, it's a rare disorder. If you've never seen one,
Right.
you maybe read about it in medical school. Nothing infuriates me more than to see a patient that's much older that has perhaps even seen neurologists and has not been diagnosed, or that had an unnecessary liver biopsy. We've all been there. So I get very excited when I see the babies. They're usually siblings of other families or got picked up because maybe they had speech delay or autism, and then they did genetic testing and a panel for that picked them up. So I get very excited because it's a good opportunity to start that education early. You're not in a rush to start any medication yet, but then you can start informing the family, these are gonna be our options, this is what we're gonna start thinking about it. But yeah, we can still do all the other things, like the nutritional changes, you know, the bracing, the therapy, like it all becomes part of their normal routine from an early age. And I think that does make a difference, right? And then we have a little bit of leisure of that time to then get more data, have new clinical trials come out, have new drugs come out, and you could educate them ahead of time. Hey, this new drug is gonna be coming out. Probably we expect it in this time frame, and by then your child will qualify, and this is what we're gonna need to be doing. So it gives you a little bit of that opportunity to do that education ahead of time. So it's exciting, but I agree, it's very scary because then you're gonna be looking to us for recommendations, and the truth is that it's a gap. We don't really know what to do when for patients that are younger. I mean, most of us now probably would agree that we would start steroids by 2, but Some people could even start it earlier, and now we're looking at that, at those trials to see, because we know the minute the child is born that you already have deficits, you already have. I don't know that I will call them asymptomatic or pre-symptomatic. If you look hard enough, you could probably find some symptom, right? But when do we start those treatments, and how safe is it to start those treatments? And that's a dilemma that we're dealing with as providers, but we'll all learn together as time goes on. But if we don't get newborn screening and we don't start diagnosing them earlier, there's not going to be a need to really do those clinical trials and include the patients that are younger. So I'm very excited that it's changing. It will be a gray zone for a time being, but hopefully a few years down the road we'll have better answers.
Yeah, I think we're moving towards better times. I think you've got a point that a stitch in time saves 9, right? Right, early on intervention. And I think in my experience with these families where they had newborn screening in Ohio at that time for the study, they, after getting over that whole shock, they basically realized that it's better to know now, put in place all interventions that's early that can delay presentation and consequences. I think the therapeutics then come in because we now have 21 companies doing Duchenne studies and trials. We have, I can count right now, we have 8 to 10 clinical trials for these families in clinic to decide. And you can only be in one trial at one time. And really, you're right that we do not have a treatment for any of our boys. I don't start steroids till about 3 because then they can run and you can assess the response, because for any drug, I need to know what the response is in order to titrate, right? So, but I take comfort that, the percent muscle mass for our boys remains at about 70% at even 5. So it's good to know that, remember, they're growing and developmentally they make progress because, the lean muscle mass still increases until 12 for our Duchenne boys. And so, but I would say that the window probably up to about the time when they present, it's about 3 to 5. And when you do look at the body composition, they basically are about, if you're not too big and on the 90th percentile for weight and BMI, most of our kids have about 65 to 70% lean muscle mass. And when you have 70% lean muscle mass, you can run, you can do stuff, but you don't run as fast. There's a difference. So the key period for this time really is all the inflammation and the pathology that is leading to all that muscle weakness, because the inflammation comes the weakness, and you give steroids in 6 months. It can be night and day for the super responders. So basically, my take on this is that during this period, if we could control the inflammation, then you can see the increased motor function because they get stronger because we address the inflammation. But at the same time, they also slow down the rate of loss. So there's a time to really focus on that, and then I wouldn't fret too much about there's no treatment for 0 to 2, because I have that cushion of that lean muscle mass for any drug substrate to work on. And if it's an effective drug, then that will translate to changes in a meaningful way. So I think that's how families kind of feel encouraged to know that though they're newly diagnosed, but we have that window still, and do the basics, right? And once you get the basics done, then all these new drugs, which I foresee will be available to the younger patients as we have more experience on all the, from the real world data of those that we have treated, to know what's the more precise benefit risk ratio or benefit burden ratio. So I think then we can now move on really quickly to like how do we advise then for the patients who are eligible for trials to choose from six or exon skipping trials to, you saw the whole list that Dr. Mike Kelly had shown us. Like, it's always a struggle in clinic, which trial should I go for? So I know you've got experiences with that, so let's kind of hear a little bit from the other centers.
You know, like we were saying before, I think it depends a lot into the family, but every patient that I see in clinic, I see patients with Duchenne every Thursday, and I love to draw in my little whiteboard, and I ask them to take a picture after of everything I draw. I'm very visual, so I hope that helps to other people. And I go through, you know, we have, for example, I divided with steroids, right? And then we have exon skipping, we have genetic therapy, we have modifier like givinostat. And I go through each of the options that are approved if it's for that patient, right? If it's a possibility for that patient. If the patient does not have any other possibility, that's when I start going through, you know, these are the options right now. I think the families have to understand what it takes to be in research, which is very important for us to do the research, but it takes a lot, right? It takes a lot of their lives. It takes a lot of the child. I mean, to me, I really hope the day that we don't have to do muscle biopsy every time we do a trial, because it's a lot, right, for the kids and the traveling. And so I think it depends. Again, I have families that are so eager and they have read about it and they look into it. So those are the easy families. The ones that don't read are the ones that I have to do the more educated, you know, decision of these are the possible, this is what we have available right now. We also have available these, and go one by one. That's why I spend so much time on each room. My husband doesn't understand why I talk for an hour or hour and a half. But it's like, that's the only way you're gonna be able to talk to them. And I literally draw everything. They take a picture and I'm like, okay, second. And then we go again. And I'm sure they don't get, they get hopefully 50%, I will say. So we have to go back and talk again. And sometimes they send me texts and asking a question. And so it's a really fluid process. I don't think it's a one-time decision, unless, because I have been educating them about what is coming, for example, with exon 44. So when I knew it was coming, so I kept telling the family, it's coming, it's coming, it's coming. When it came, it was very easy with exon 44 amenable. They were like, okay, yeah, we're doing it. So education ahead of time on every appointment helps a lot in making that decision for me. So
that's true. It's an informed consent process, and it starts from like a year before they get to sign that on the paper.
Yeah, it's rare the situation where you can just enroll the patient. But again, like 44, we have been talking about exon 44 for so many years. Finally came, it wasn't difficult to enroll because the patients were waiting, right?
And I think you highlighted that whole importance of therapeutic misconception. I think for our families who are interested in trials, it's always a reminder that it's research, it's a therapeutic trial, it's not a therapeutic drug that is approved, so that in going to be enrolled, one is going in with the mind that this is not treatment, but it's a promising treatment if after the research trials confirm that it is effective. So I think that's hard because I find that we can emphasize a lot of this whole importance of understanding therapeutic misconception, but I can understand the families. You know, it's hard when the trial fails. You know, each time when there's a negative trial, a lot of tears, a lot of sadness, which but they have coped well. But that is so true that we tend to go in, is there a trial for me? Is there a trial? And they look at the trials as, I find that they just blot out that whole thing about this is really contributing to research. But if it works, then, you know, you benefit me, you benefit the community. So I think that's one one thing that I've come across.
And I was going to make a quick comment about including the patients. I think that obviously a little kid is not going to be able to understand, but after a certain age, I make sure that they are sitting there, and I make sure that they understand. I swear, they obviously understand really well. Many of them, they understand what you're telling them, and like you show them the exon, the little app with all the exons. So if you take this one, this happen. So I'm finding that a lot of the patients actually, the ones that are between like 12 years, around that age, they're saying, I want to do it. I want to do this. I want to do this. I mean, they are understanding the importance, and I love having some of them because this is going to help some people. Like some of them say that, and I think it's the most amazing thing that kid, can do something that early. But to me, it's very important. Whoever you go to, whoever physician you go to, make them include the child in the conversation and in the clinic. Don't let them just talking to you. I mean, you don't, try to break that from the beginning. Let them be the patient, and you're the mom or the dad that is, So I'm sitting there, I sit with my kid, and I talk to them, are you pooping okay? And they turn and look at the mom. And I'm like, sweetheart, you're the one pooping. Tell me about the poop. So we talk about the poop. Interesting that when they are adults, they come with the wife, so they look at the wife now, which I don't understand. But very important.
They're dependent on women.
Oh my God, 100%. But it's very important that really make them aware of what's going on, make them understand. Don't put them in the corner and make decisions for them without having, even if they are little, they can still be part of the decision.
I think it's hard when you have drugs that are approved that are competing with drugs that are on clinical trials, and that's where it gets a little bit trickier, right? For families to decide, do I take the standard of care that we know has already been proven and it has certain efficacy versus a different drug that's being studied that we still don't know how effective it's going to be or not. And I think that's what's a little bit trickier, and a lot of times families will look up to us, and I say, but it's your decision at the end of the day is what you feel comfortable with, and again, kind of educating like the differences perhaps in the mechanism of action and how the drugs work, and for them to understand maybe the medical part of it, but it's a risk that it has to be individualized. It's an individual decision. Some people are very risk aversive, and they'll say, I'm going to go with the standard and what I know is proven to work. And some people are willing to take that risk perhaps for something that might be more effective. And that's where it's individual, right? Where every family is going to be different. I think there's some families that are not even open to talk about clinical trials, and that's okay too. Yeah. And then you just have to educate them, at least to get them on the standard of care, and you spend all your time doing that. And some families are very eager to know everything that's available. Where else can I go? And you have to be able to provide that information for them. And if it's not a trial that you have at your site, be able to connect them with other places where they could go. Having that relationship with those clinical trial sites and understanding the criteria, right? Because a lot of times, if they haven't been on steroids perhaps long enough, or they have to be on a stable dose of steroids for a certain amount of time, usually 3 or 6 months, don't even make the trip for a screening visit because you're gonna fail. So I could save them that time if I take the time myself to look at that inclusion criteria, and then be able to tell them, like, I think you will qualify, go, or you're not there yet, maybe don't make the trip yet. But I think that's where it's important to have that relationship with your providers and your families. And then the providers having the relationships with other clinical trial sites that you might be referring them to.
And to add to that point, and I think the sponsors are really good these days. They have the parent advocacy involvement as well. And I think we've had, like, when let's say the patient's looking for a trial and the site doesn't have, they usually can be contacted to recommend them to the nearest site, and the sponsors usually contact the sites and say, I've got this patient, and so I think there is that connections out there to help the families navigate to a trial that their son may be eligible to if their own care site doesn't provide the trial, because it's impossible for a site to do all the trials, staffing issues and limitations, but certainly I think it's a huge community here. We have the clinics, we have the sponsors, we have the advocates, and it make it work. And so I'm glad that with the way things have exploded, we also see the community resources coming up to help them navigate the trials together with their care providers at their sites. And I think we have kind of reached 11 o'clock now, that I would just want to summarize maybe a little bit of what we had planned to do with Dr. Mammon. Dr. Mammon is our colleague in the adult cardiomyopathy clinic, used to be at UT Southwestern, now he's at Kansas, and he is very familiar to our older Duchenne patients and the carrier moms. And so his vast experience in Duchenne cardiomyopathy, that's what we look up to. And he'll be here tomorrow, I think, to present, but he's not here. But we actually had wanted to hear his update on the cardiac front. And, I'm so glad that I don't see a lot of patients with cardiac failure these days. When I first started many years ago in Cincinnati, we lost boys, young boys like 14, 15, one was 10, to cardiac failure. But then there was none. I did not lose any of my patients to that till probably 2019, and then we had another patient who had cardiac failure, and we passed probably like just 2 years ago. So it is encouraging to me that with the cardiac front, we have very little morbidity, and that's because there is that very proactive cardioprotection protocol in place with lisinopril, the ACE inhibitors, the beta blockers, the spironolactone, abiraterone, with the spotting of fibrosis at age 10, cardiac MRI, and some even do it prophylactically, right, after age 10. And Dr. Mammon was to kind of walk us through the adult experience with the fourth addition of the SGLT2 inhibitors for the adult heart failure population. That had been great, and I know some of our older patients, by the time they are late teens and 20s, may have been started on the SGLT2 inhibitors, and I think that one is understood to not only help the heart, but metabolic, because it also works on like diabetes, and for our families, for our patients that's been on 20 years of steroids and 25 years of steroids, you're starting to see not a lot of diabetes, thank goodness, but pre-diabetes. And I think with that whole additional benefit on metabolic and then renal, so that in the adult world, they said that they should have a multidisciplinary clinic for cardiac, metabolic, and renal providers, because they use one drug and they manage all three. So, but I think I know Dr. Mammon has a lot of more experience dealing more with our older patients. So I thought that would be just adding on to the fact that the standard of care, not only steroids, and then the pulmonary is doing really well with the cough assist airway clearance and the non-invasive BiPAP. And if you do that well, you're in good shape, right? Very good shape. And then cardiac, we have these 4 drugs with more to come as we hear about like Deramucil, we hear about Ifetroban, and we're going to hear the update on the Saducor's, like Circus gene therapy for cardiomyopathy. So it's been just, we have always said it's so slow, all these changes, but then if you see the number of trials and medications, and more importantly, the fruit of the pudding is our boys. They are doing so much better. It's a new generation, and I think indeed we have come a long way. There's still a long way more to go, but certainly with the families, with just the community, and with organizations and support groups like Cure Duchenne's, I expect faster changes. I think the treadmill is going to go faster. So hang on tight before we all fall out. But thank you so much for this time of sharing. And I would like to thank everybody for giving us this time to just share our thoughts and our take on the events that have happened for the last 20 years. Thank you.
Thank you so much.
We have a little surprise too coming up. As you guys know, Dr. Wong has more than 20 years experience in pediatrics, 25 years in pediatric neurology, well, I can't speak. She directed the Comprehensive Neuromuscular Center at Cincinnati Children's Hospital and more recently founding director of the Duchenne Muscular Dystrophy Center at Massachusetts Memorial Medical Center and professor of pediatrics and neurology at the UMass Chan Medical School, and most recently in January, our new chief medical advisor. So we have a little surprise for you if we want to look, yeah.
We're so excited to have Dr. Brenda Wong join us here at Futures this year. And I know that many of you have spent time with Dr. Wong in her office at UMass and have many wonderful stories as we do. I know the first time that we were waiting in a treatment room to meet Dr. Wong, the very first time. And when she walked in, it was like an angel had walked into the room. It was a breath of fresh air with hope and light. And Brenda has so many endearing qualities beyond her expertise with Duchenne. Many of us know that when she's doing assessment, she's writing in ink on her hand what those results are. All of us know that when we've been waiting in a treatment room, we can hear the clack, clack, clack of her heels walking down the hall as she's going back and forth between the treatment room, seeing so many patients in one day. Most of all, Brenda has been a pioneer. She has led this field. She created the multidisciplinary clinic for Duchenne care. And we are so grateful to Dr. Wong for her many years of dedication to our community. We love you, Brenda.
Thank you, Dr. Wong. We're forever grateful.
Yes.
Everybody!
So yes, this is a Lifetime Achievement Award for Dr. Brenda Wong. We're so grateful to have her part of the team going forward and just for all the work that she's done to help so many guys with Duchenne.
Thank you. Thank you all. Thanks, Alton. You were a little boy when I first met you. That shows how old I am. But thank you all for this opportunity in this journey of hope. And it is a journey of hope. And I can attest to that. Like, as I told Tim Ravel in Austin many years ago at my first parent meeting in Austin when Timothy was just 3 years old, that we will reach the day when it was that last slide where it's bright skies, the sun is out, and we are getting there. And I know days will get brighter.
Yes,
Thank
they
you.
will.
I am very old.
No, you're not.
So nice. Oh, you're the best. No, there'll be more to come.
Sometimes I just can't take it. Sometimes I just can't take it, and it isn't alright. I'm not gonna make it, and I think my shoes untied. I'm like a broken record. I'm like a broken record, and I'm not playing right. Just cynical, how about you kill me till you tell me on the heavenly phone. So hold tight. Come on, come on. Oh, come on, come on. Don't let go. Hold tight, hold tight. It's alright, you said. I got my hands up shaking just to let you know that you've got a higher power. Got me singing every second, dancing every hour. Oh yeah, you've got a higher power, and she really someone I wanna know electric. This boy is electric and you're sparkling like the universe connected. And I'm buzzing night after night after night. This joy is electric. This joy is electric and you're circuiting through. I'm so happy that I'm alive. Happy I'm alive at the same time as you. 'Cause you've got a higher power. Got me singing every second, dancing every hour. Oh yeah, you've got a higher power. And you're really someone I wanna know. You got, yeah, you got a high. You got, yeah, you got a high. Yeah, you got, yeah, you got a high. You got, you got, you got a high. You got, yeah, you got a high. Yeah, you've got, you got a high. My hands up shaking just to let you know now. You've got a higher power. You got me singing.